Welcome back to Government School. Today I'll be discussing clinical approach to cardiomyopathies. First of all, we should define cardiomyopathy. As per Harrison, cardiomyopathy is a disease of heart muscles where the heart muscle is structurally or functionally abnormal, structurally and functionally abnormal in the absence of major diseases like coronary artery disease, hypertension, valvular heart disease, or congenital heart disease, which are sufficient to cause observed myocardial abnormality. So we can say that the definition of cardiomyopathy is a diagnosis of exclusion, a structural and functional abnormality of the heart muscle where it is not due to known cardiac problems like coronary disease, hypertension, valvular disease, and congenital heart disease. So the major point to be remembered is that this is a disease of exclusion. Suppose a patient has got a 3-vessel coronary disease and they come with features of heart failure, or patient has got uncontrolled hypertension. The cause is not cardiomyopathy, it is due to these basic diseases. So now we go into the classification. Cardiomyopathies are basically divided into 4 main types, and first is the dilated cardiomyopathy. In dilated cardiomyopathy, it is a pathologically there is a dysfunction in the systole. So there is a systolic dysfunction. Heart is unable to contract properly. The heart is dilated, so it is enlarged, it becomes globular. Rather than acting as a pump, it acts as a reservoir. That is the concept you remember. So the heart is weak and weak. At the same time, the pumping is ineffective, so the ejection fraction is less and the patient has got a dilated heart. So the key point is there are 2 types of cardiomyopathy. One due to known causes. For example, alcohol can produce, other toxins, chemotherapeutic drugs like arrhythmias, viral myocarditis, all these can lead on to. Among them, one important thing is the pregnancy related, that is the peripartum cardiomyopathy. So these are all primary causes, and there is no cause is there. Many of them are due to genetic disease like mutations in the TTN. So primary and secondary. Once you remember the DCM, the second type is HCM. It is a hypertrophic cardiomyopathy. The heart is thickened. So here it is dilated. Here the hypertrophic cardiomyopathy, what is happening? The heart is thickened. And usually there is a septal hypertrophy. Asymmetrical septal hypertrophy can occur. And as the muscles are hypertrophied, here the main problem is diastolic dysfunction. The ventricle fails to relax properly. So DCM is a systolic dysfunction, whereas the hypertrophic cardiomyopathy is a diastolic dysfunction. The most common genetic cardiovascular disease probably is hypertrophic cardiomyopathy. So the patient collapses during exercise. Always remember, the patient is having hypertrophic cardiomyopathy unless proved otherwise. So this point you remember, a strenuous exercise, somebody collapses, remember hypertrophic cardiomyopathy. Now we go to the third cause, the restrictive cardiomyopathy. So the heart is stiff and infiltrated heart. So going back to hypertrophic cardiomyopathy, in hypertrophic cardiomyopathy, the obstruction to the outflow tract is dynamic. It is a dynamic obstruction. When the ventricles are full, the obstruction is less. So any condition that increases the diastolic volume or the volume in the heart will decrease the obstruction, whereas anything that decreases the ventricular size will increase obstruction. So what happens in squatting? Obstruction comes down, because in squatting there is increased volume in the heart, whereas when you stand up, the preload is decreased and the obstruction is increased. So this we will discuss during dynamic auscultation. So the third cause or third type is restrictive cardiomyopathy. The pathophysiology is usually the right ventricular walls resist filling. So here it was left ventricle, here the right ventricular walls is a restriction. The filling is decreased. The clinical clue that you should remember is always look for systemic causes like amyloidosis, amyloid, sarcoidosis, and hemochromatosis. So these are usually restrictive cardiomyopathy. There is a restriction in the right ventricular walls and is usually associated with a systemic disease like hemochromatosis, sarcoidosis, and amyloidosis. So we have said about three types: dilated, hypertrophic, and restrictive. Now we go to the third one. For the fourth one, this arrhythmogenic right ventricular cardiomyopathy, otherwise called ARVC. The heart is fatty and unstable. So the pathophysiologically, the myocardium is replaced with fat and fibrosis. So that is why it is called fatty heart, fibrosis. But at the same time, this is prone for arrhythmias. So the triad of dysplasia occurs in the RV inflow, the inflow to the right ventricle, outflow to the right ventricle, and the apex. So suspect arrhythmogenic right ventricular cardiomyopathy whenever patient develops VT or arrhythmias, ventricular arrhythmias, especially VT with the LBB pattern. So again, we will discuss this later. So remember, arrhythmogenic right ventricular cardiomyopathy. So these are the four major causes of cardiomyopathy. When you are approaching clinically, always think about family history. Take a genetic history. If anybody in your family had undergone or had suddenly died under the age of 40, it is crucial in hypertrophic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy. So arrhythmias. Is the tempo is rapid onset. Suppose the course of the disease is very rapid. Think about causes like toxins, myocarditis, or viral myocarditis. Think about it. If it's low, it is likely to be genetic or infiltrative causes. Then look for the physical clues. Already mentioned, the restrictive cardiomyopathy is associated with the amyloidosis. In amyloidosis, you can get a large tongue or macroglossia. So macroglossia is one feature. Second, periorbital purpura is otherwise called the raccoon eyes. So these are two signs that you can look for. Again, there can be carpal tunnel syndrome. Hypertrophic cardiomyopathy, you will get murmur and you can identify during dynamic auscultation. That is when the ventricular volume is less, obstruction is more. So standing, the murmur increases. So today we have discussed about the classification of cardiomyopathy, some clinical clues. In the next session, I will be discussing some of the clinical examples or clinical scenarios where the cardiomyopathy comes and how will you manage it. Stay tuned. Thank you.